Question 1. Mr. Davis is a 55-year-old patient with a diagnosis of type 2 diabetes. His most recent HbAC result was 9.2% and his fasting blood glucose levels are consistently above 200 mg/dL. He is currently prescribed metformin but has not achieved adequate blood glucose control. In addition to adjusting his medication regimen, what should be emphasized as part of his diabetes management plan to improve his glycemic control? They focus on dietary changes that emphasize high-protein, low-carbohydrate meals. B. Recommend a weight loss strategy that includes bariatric surgery if necessary. C. Recommend a structured physical activity program, including both aerobic and resistance exercises. D. Encourage Mr. Davis to use insulin as soon as possible without considering other alternatives. Answer. C. Recommend a structured physical activity program, including both aerobic and resistance exercises. Explanation. In managing type 2 diabetes, lifestyle interventions such as exercise and diet are critical components of therapy. Studies show that a combination of aerobic and resistance exercises can significantly improve insulin sensitivity and reduce blood glucose levels. According to the American Diabetes Association, regular physical activity, at least 150 minutes per week, is essential in managing type 2 diabetes. Weight loss through diet can also play an important role, but physical activity is a cornerstone of non-pharmacological treatment. While bariatric surgery may be an option for some patients with obesity-related type 2 diabetes, it is typically considered only after other strategies have been attempted. Immediate insulin without addressing lifestyle changes is not advisable because it does not address the root causes of insulin resistance and obesity, which are often the underlying issues in type 2 diabetes management. Question 2. Which of the following best describes the role of glucagon in blood glucose regulation? A. Glucagon promotes the uptake of glucose into muscle cells for storage. B. Glucagon inhibits glucose release from the liver, thus lowering blood glucose levels. C. Glucagon stimulates the liver to release glucose into the bloodstream, raising blood glucose levels. D. Glucagon is responsible for converting glucose into glycogen for storage in the liver. Answer. C. Glucagon stimulates the liver to release glucose into the bloodstream, raising blood glucose levels. Explanation. Glucagon is a hormone produced by the alpha cells of the pancreas and plays a crucial role in maintaining blood glucose levels. When blood glucose levels drop, glucagon is released to stimulate the liver to release stored glucose glycogen into the bloodstream, which raises blood glucose levels. This process is for preventing hypoglycemia and ensuring the body has a steady supply of glucose for energy. Unlike insulin, which lowers blood glucose levels, glucagon works to raise blood glucose levels when they are too low. Glucagon does not have a direct role in storing glucose or inhibiting glucose release from the liver, as indicated by the incorrect options A and B. Question 3, scenario-based. Sarah, a 40-year-old woman, is pregnant and has recently been diagnosed with gestational diabetes. Her doctor has prescribed a blood glucose monitoring plan, which includes daily fasting glucose checks and post-meal glucose testing. During her latest visit, her fasting blood glucose was 110 mg/dL and her post-meal glucose was 109 mg/dL. What should Sarah do in response? These readings. A. She should immediately start insulin therapy because the readings are too high. B. Sarah should increase her carbohydrate intake to prevent hypoglycemia and retest in 1 week. C. She should follow up with her healthcare provider to discuss adjusting her medication and diet plan. D. Sarah can continue with her current management plan as her blood glucose levels are within acceptable range. Answer. C. She should follow up with her healthcare provider to discuss adjusting her medication and diet plan. Explanation. Gestational diabetes requires careful monitoring and management to prevent complications for both the mother and the baby. A fasting blood glucose level above 95 mg/dL and a post-meal glucose level above 100 mg/dL are often used as thresholds for diagnosis and monitoring. Sarah's fasting glucose 110 mg/dL is above the target range for gestational diabetes management, and her post-meal glucose of 109 mg/dL is also elevated. These readings suggest that her current treatment plan may need adjustment, including changes to her diet or medication. It is important to consult with her healthcare provider to ensure optimal management and reduce the risk of complications such as fetal macrosomia, preeclampsia. Simply increasing carbohydrate intake or continuing the current plan without adjustments could result in poor outcomes. Immediate insulin use option A is not always necessary if lifestyle changes or oral medications are effective. Question 4. Mr. Thompson is a 60-year-old patient with type 2 diabetes. His HbAC has been consistently around 8.5% despite following his prescribed medication regimen of metformin and a sulfonylurea. He reports moderate adherence to his diet but struggles with his exercise routine due to joint pain. Additionally, his blood pressure is elevated and his lipid profile shows high triglycerides and OAD. Cholesterol. What would be the most appropriate next step in his diabetes management plan? A. Increase the dose of his sulfonylurea to improve glycemic control. B. Start a ion receptor agonist considering his cardiovascular risk factors and the benefit of weight loss. C. Add thiazolidine into his regimen as it will help improve both his glycemic control and lipid profile. D. Recommend more intensive lifestyle changes without adjusting his medication regimen. Answer. B. Start a ion receptor agonist considering his cardiovascular risk factors and the benefit of weight loss. Explanation. Mr. Thompson's elevated HbAC and risk factors, including high blood pressure and dyslipidemia, point to the need for a more comprehensive approach. GLP-1 receptor agonists, such as liraglutide and semaglutide, have shown effectiveness in improving blood glucose control, promoting weight loss, and cardiovascular risk factors such as hypertension and dyslipidemia. The AIDA guidelines recommend GLP-1 receptor agonists for patients with type 2 diabetes and high cardiovascular risk. Increasing the sulfonylurea dose option A may increase the risk of hypoglycemia and does not address his cardiovascular concerns. Thiazolidines option C can help with insulin resistance but have potential adverse effects including gain in fluid retention. While lifestyle changes are essential, option D, they should complement, not replace, pharmacological therapy in patients with poor glycemic control. Question 5. When interpreting an HbAC result for a patient with diabetes, which of the following is true regarding its limitations and utility in managing the patient's condition? A. HbAC is a reliable indicator of short-term glycemic fluctuations but is not useful for long-term control. B. HbAC results are unaffected by variations in red blood cell lifespan and do not require adjustment for different populations. C. Low HbAC may indicate well-controlled diabetes, but it may also mask episodes of hypoglycemia if blood glucose variability is high. D. HbAC is the most accurate test to assess immediate blood glucose control after meals and should be used to adjust insulin dosages. Answer. C. Low HbAC may indicate well-controlled diabetes, but it may also mask episodes of hypoglycemia if blood glucose variability is high. Explanation. HbAC is a measure of long-term blood glucose control, reflecting the average glucose levels over the previous 2-3 months. While it is a useful tool for assessing overall glycemic control, it has limitations. Low HbAC result does not necessarily mean that blood glucose levels are stable. In fact, it may mask significant fluctuations or episodes of hypoglycemia, which could occur between testing periods. The HbAC result is not a reliable measure of short-term fluctuations, option A, nor does it accurately reflect the effects of meals on glucose levels, option D. Additionally, in populations with conditions affecting red blood cell turnover such as anemia, HbAC results may be and need to be interpreted carefully, option B. Question 6. Ms. Ramirez, a 45-year-old woman with type 1 diabetes, is experiencing frequent episodes of hypoglycemia despite following her prescribed insulin regimen. Her insulin regimen consists of a long-acting insulin, Glargine, once daily, and a rapid-acting insulin, Aspart, before meals. She has a physically demanding job and often works long shifts. What adjustment could help reduce her risk of hypoglycemia? Maintaining good glycemic control. A. Decrease the dose of her long-acting insulin to prevent low blood glucose during the night. B. Introduce an insulin pump to allow for more precise insulin delivery and adjustments based on activity levels. C. Switch to a higher dose of rapid-acting insulin before meals to improve postprandial glucose control. D. Discontinue her insulin therapy and recommend oral medications for type 1 diabetes. Answer. B. Introduce an insulin pump to allow for more precise insulin delivery and adjustments based on activity levels. Explanation. For individuals with type 1 diabetes who experience frequent hypoglycemia despite insulin therapy, an insulin pump can provide more precise and flexible insulin delivery. The pump allows for continuous basal insulin infusion, which can be adjusted based on the patient's activity levels. Insulin sensitivity. This flexibility can help prevent hypoglycemia during periods of increased physical activity, which may be contributing to her episodes. Decreasing the long-acting insulin dose option A may increase the risk of hypoglycemia and does not address the variability in her glucose levels due to activity. Increasing the rapid-acting insulin dose option C would only exacerbate hypoglycemia after meals. All medications are not effective for managing type 1 diabetes, option D. Question 7. Mr. Harris, a 70-year-old man with type 2 diabetes, presents with symptoms of diabetic peripheral neuropathy, including numbness and tingling in his feet. His HbAC has been well controlled at 7.0%, but he has been experiencing increasing difficulty walking and a decreased quality of life. Which of the following interventions should be prioritized in his care plan to address both his diabetes and neuropathy? A. Initiate a course of oral corticosteroids to reduce inflammation and swelling. B. Prescribe a neuropathy-specific medication such as pregabalin or gabapentin for pain management. C. Recommend an increased dose of his metformin to improve nerve function. D. Increase his daily insulin dose to achieve a tighter control of his blood glucose levels. Answer. B. Prescribe a neuropathy-specific medication such as pregabalin or gabapentin for pain management. Explanation. Diabetic peripheral neuropathy is a common complication of diabetes, and managing the symptoms requires a comprehensive approach. Medications such as pregabalin and gabapentin are first-line treatments for neuropathy-related pain. These drugs target nerve pain and can significantly improve the patient's quality of life by alleviating symptoms such as burning, tingling, and numbness. While controlling blood glucose is important for preventing further nerve damage, tighter glycemic control, option D, or increasing the dose of metformin, option C, will not directly address the neuropathic pain. All corticosteroids, option A, are not indicated for neuropathy and may worsen glucose control. Therefore, addressing the pain with appropriate medications is the priority. Question 8. Which of the following is true about the use of SGLT2 inhibitors in the management of type 2 diabetes? A. SGLT2 inhibitors lower blood glucose by increasing the renal reabsorption of glucose, thereby increasing blood glucose levels. B. SGLT2 inhibitors have been shown to reduce the risk of cardiovascular events and kidney disease in patients with type 2 diabetes. C. SGLT2 inhibitors are contraindicated in patients with normal renal function and should only be prescribed to those with impaired kidney function. DS2 inhibitors primarily act by enhancing insulin secretion from the pancreas. Answer. SGLT2 inhibitors have been shown to reduce the risk of cardiovascular events and kidney disease in patients with type 2 diabetes. Explanation. SGLT2 inhibitors, such as empagliflozin and canagliflozin, work by inhibiting the sodium-glucose cotransporter 2 in the kidneys, which prevents glucose reabsorption and promotes glucose excretion in the urine. This mechanism helps lower blood glucose levels. Additionally, studies have shown that SGLT2 inhibitors reduce the risk of cardiovascular events and slow the progression of kidney disease in patients with type 2 diabetes, particularly those with established cardiovascular or kidney conditions. They are not contraindicated in patients with normal renal function, option C, and they do not act by enhancing insulin secretion, option D. The incorrect option is also incorrect because SGLT2 inhibitors decrease renal reabsorption of glucose, not increase it. Question 9. MS Patel is a 35-year-old woman with a recent diagnosis of type 2 diabetes. She is obese with her ER of 32 and has a family history of diabetes. After her diagnosis, she was prescribed metformin and advised on lifestyle changes, including dietary modifications and regular exercise. Despite her efforts, she is concerned about the long-term management of her diabetes and asks if weight loss surgery, bariatric surgery, might be an option for her. What is the most appropriate response regarding bariatric surgery in her case? A. Bariatric surgery is not recommended for anyone with type 2 diabetes unless their HbAC is above 10%. B. Bariatric surgery may be a good option for patients with type 2 diabetes who have a ER of 30 or greater and are unable to achieve sufficient weight loss with lifestyle interventions. C. Bariatric surgery should only be considered if the patient is at least 45 years old and has had type diabetes for more than 10 years. D. Bariatric surgery is not effective in treating type 2 diabetes and should not be considered in any case. Answer. B. Bariatric surgery may be a good option for patients with type 2 diabetes who have ER of 30 or greater and are unable to achieve sufficient weight loss with lifestyle interventions. Explanation: bariatric surgery is increasingly recognized as an effective treatment for type 2 diabetes in patients who are obese and have difficulty achieving weight loss with lifestyle changes alone. The American Diabetes Association recommends bariatric surgery for patients with type 2 diabetes who have a BR of 30 or greater, especially when they have not achieved adequate blood glucose control through lifestyle interventions and medications. Bariatric surgery can lead to significant weight loss, improved insulin sensitivity, and in some cases, remission of type 2 diabetes. The guideline does not set an age or duration requirement for surgery. Option C. Assertion that surgery is not effective. Option D is inaccurate given the evidence supporting its benefits. Question 10. A 58-year-old man with a 10-year history of type 2 diabetes presents to the clinic for a routine checkup. His blood pressure is 145/90 to Hg and his HbAC is 7.4%. He has an ER of 34 and reports moderate exercise 3 times a week. His lipid profile shows elevated LDL cholesterol and triglycerides. He is currently on metformin and a statin. Dyslipidemia. Given his cardiovascular risk factors, what would be the most appropriate next step in managing his diabetes and overall health? A. Increase the dose of metformin to further reduce his HbAC. B. Start a second oral hypoglycemic agent, such as sulfonylurea, to lower his blood glucose levels. C. Add an SGLT2 inhibitor to reduce cardiovascular risk and improve glycemic control. D. Discontinue the statin and switch to a fibrate to better control his lipid levels. Answer: C. Add an SGLT2 inhibitor to reduce cardiovascular risk and improve glycemic control. Explanation: given the patient's history of type 2 diabetes, elevated blood pressure, dyslipidemia, and a BR suggesting obesity, he has significant cardiovascular risk. SGLT2 inhibitors such as empagliflozin and canagliflozin are proven to lower HbAC, reduce the risk of cardiovascular events, and improve function in patients with type 2 diabetes, especially those with cardiovascular risk factors. Increasing the dose of metformin, option A, may not address his cardiovascular concerns. Adding a sulfonylurea, option B, could increase the risk of hypoglycemia and doesn't target his cardiovascular risk. Discontinuing the statin, option D, is inappropriate as statins are effective in managing dyslipidemia and reducing cardiovascular risk. Question 11. Mrs. Clark is a 72-year-old woman with a history of hypertension and hyperlipidemia, diagnosed with type 2 diabetes 3 years ago. She currently takes metformin and a statin, and her HbAC has been well controlled at 6.9%. Recently, she has noticed increasing fatigue, frequent urination, and persistent thirst. Upon further investigation, her serum creatinine is elevated and her albumin to creatinine ratio is 200 fit mdg. What is the most appropriate management for her diabetic kidney disease? A. Increase the dose of her metformin to control her blood glucose more aggressively. B. Add an ACE inhibitor or ARB to reduce proteinuria and protect renal function. C. Discontinue her statin and start a fibrate to better manage her lipid levels. D. Recommend a low-protein diet to prevent further kidney damage. Answer: B. Add an ACE inhibitor or ARB to reduce proteinuria and protect renal function. Explanation: Mrs. Clark's elevated urine albumin to creatinine ratio indicates the presence of diabetic kidney disease (DKD), common complication of diabetes. The most effective intervention for preventing the progression of DKD is the use of an ACE inhibitor or angiotensin receptor blocker (ARB). These medications help reduce proteinuria, lower blood pressure, and protect kidney function. Increasing metformin, option A, may not be appropriate given her elevated serum creatinine, as it can be contraindicated in patients with significant renal dysfunction. Discontinuing the statin, option C, is not recommended as statins reduce cardiovascular events and are beneficial in diabetic kidney disease. Low-protein diet, option D, may be helpful but should be relied on as the primary treatment for DE. Question 12. A 65-year-old woman with type 2 diabetes presents to the clinic with a history of frequent episodes of hypoglycemia. She is currently taking insulin glargine once daily and insulin aspart before meals. Her HbAC is 7.2% and she reports that her blood glucose levels fluctuate significantly. She is concerned about the risk of hypoglycemia, particularly during exercise. What is the appropriate adjustment to her insulin regimen? A. Increase her basal insulin glargine dose to improve overall glycemic control. B. Switch her to an insulin pump to allow for more flexible dosing based on activity. C. Decrease the dose of her bolus insulin aspart to reduce the risk of hypoglycemia after meals. D. Add a E1 receptor agonist to help with weight loss and improve her overall diabetes control. Answer: B. Switch her to an insulin pump to allow for more flexible dosing based on activity. Explanation: for patients who experience significant fluctuations in blood glucose levels and frequent episodes of hypoglycemia, insulin pumps can provide a more flexible and tailored insulin regimen. Pumps deliver continuous basal insulin and allow for more precise adjustments based on the patient's activity level, thereby reduce risk of hypoglycemia during exercise. Increasing the basal insulin dose, option A, would likely exacerbate hypoglycemia. Decreasing the bolus insulin, option C, may increase the risk of hypoglycemia after meals. Why GLP-1 receptor agonists can help improve overall control and aid in weight loss. They are not the first-line solution for managing hypoglycemia in this patient, option D. Question 13. Mr. Daniels, a 62-year-old man with type 2 diabetes, is presenting with a new diagnosis of diabetic retinopathy. His HbAC has been fluctuating around 8.0% despite his adherence to a metformin and sulfonylurea regimen. His blood pressure is 145/9 Hg and his lipid profile shows high LDL cholesterol. Given the new diagnosis of retinopathy, what most appropriate next step in his treatment plan? A. Intensify his glycemic control with the addition of one receptor agonist. B. Begin laser therapy to treat the retinopathy immediately. C. Start an ACE inhibitor to manage his blood pressure and protect his kidney function. D. Recommend that he start a more aggressive lipid-lowering regimen with higher doses of statins. Answer A. Intensify his glycemic control with the addition of the receptor agonist. Explanation: diabetic retinopathy is a common complication of poorly controlled type 2 diabetes. The first line of action is to intensify glycemic control, as better blood glucose management can help slow the progression of retinopathy. GLP-1 receptor agonists are effective in improving glycemic control and have the added benefit of weight loss, cardiovascular risk reduction, while blood pressure management with an ACE inhibitor, option C, and statin therapy, option D, are important for preventing further complications. They are secondary to optimizing glycemic control. Laser therapy, option B, is indicated in advanced cases of retinopathy but is not the first step in treatment for early diabetic retinopathy. Question 14. A 55-year-old male with type 2 diabetes has recently started taking a E4 inhibitor sitagliptin to help control his blood glucose levels. He reports no significant side effects but is concerned about the long-term risks of the medication. What is the most important consideration in the long-term management of this patient who is on a E4 inhibitor? A. The risk of acute pancreatitis, which has been associated with DPP-4 inhibitors. B. Monitoring renal function, as DPP-4 inhibitors can lead to renal damage in patients with impaired renal function. C. The need for regular blood pressure checks, as DPP-4 inhibitors can cause hypertension. D. Regular lipid profile monitoring, as DPP-4 inhibitors may increase triglyceride levels. Answer A. The risk of acute pancreatitis, which has been associated with DPP-4 inhibitors. Explanation: while DPP-4 inhibitors such as sitagliptin are generally well tolerated and effective in lowering blood glucose levels, there is some concern about the risk of acute pancreatitis, which has been observed in rare cases. Patients on DPP-4 inhibitors should be monitored for symptoms of pancreatitis such as severe abdominal pain. Renal function, option B, should also be monitored. DPP-4 inhibitors require dose adjustments in patients with renal impairment, but renal damage is not a primary concern for most patients on this medication. DPP-4 inhibitors are not associated with hypertension, option C, or significant changes in lipid levels, option D. Question 15. Mr. Lee, a 50-year-old man with type 2 diabetes and hypertension, presents with a history of sudden onset shortness of breath, fatigue and swelling in his lower extremities. On examination, he has bilateral pitting edema, jugular venous distension, and crackles on lung auscultation. His recent lab work shows an elevated BNP and his renal function is stable. What is the most likely cause of his symptoms? A. Diabetic nephropathy leading to fluid retention and heart failure. B. A diabetic emergency such as diabetic ketoacidosis. C. Acute heart failure exacerbation, likely due to uncontrolled hypertension and diabetes. D. Pulmonary embolism due to recent immobility. Answer: C. Acute heart failure exacerbation, likely due to uncontrolled hypertension and diabetes. Explanation: the patient's symptoms, including shortness of breath, lower extremity edema, and crackles on auscultation, along with the elevated BNP, strongly suggest acute heart failure. His history of diabetes and hypertension are major risk factors for developing heart failure. Diabetes can exacerbate heart failure due to its effect on heart and blood vessels, particularly when blood pressure is poorly controlled. Diabetic nephropathy, option A, could contribute to fluid retention, but the primary concern here is heart failure. A diabetic emergency, option B, such DKA typically presents with other metabolic abnormalities, and pulmonary embolism, option D, would present with more acute symptoms such as chest pain and difficulty breathing. Question 16. Mrs. Walker is a 60-year-old woman with a history of type 2 diabetes, hyperlipidemia, and hypertension. She has been on an ACE inhibitor, lisinopril, a statin, atorvastatin, and metformin for several years. During her recent visit, her blood pressure is well controlled at 138 mmHg and her HbAC is 6.8%. She expresses concern about the possibility of developing cardiovascular disease. Given her diabetes, what additional steps should be taken to address her cardiovascular risk? A. Start a low-dose aspirin regimen for primary prevention of cardiovascular events. B. Increase her statin dose to a high-intensity statin to lower her cholesterol further. C. Start a calcium channel blocker to provide better blood pressure control. D. Recommend dietary changes focused on reducing sodium intake and increasing potassium. Answer A. Start a low-dose aspirin regimen for primary prevention of cardiovascular events. Explanation: given Mrs. Walker's risk factors, including type 2 diabetes and hypertension, she is at an increased risk for cardiovascular disease. Starting low-dose aspirin regimen for primary prevention is appropriate for patients with diabetes who are at high cardiovascular risk, while her blood pressure and HbAC are well controlled. Cardiovascular risk remains elevated, and aspirin can help reduce the likelihood of heart attacks and strokes. Increasing her statin dose, option B, may not be necessary if her cholesterol is adequately controlled. Calcium channel blockers, option C, are not first-line treatments for her current blood pressure levels, and dietary changes, option D, are important but unlikely to address her immediate cardiovascular risk concerns. Question 17. A 40-year-old male patient with type 2 diabetes presents to the clinic for a routine follow-up. His HbAC has remained stable at 7.1% with his current regimen of metformin and lifestyle modifications. However, his recent lab results show an increase in his serum creatinine and urine albumin to creatinine ratio. He has no symptoms but is concerned about kidney damage. What is the appropriate next step in management? A. Increase the dose of metformin to improve glycemic control and reduce kidney complications. B. Add an ACE inhibitor or ARB to help protect his kidneys and reduce proteinuria. C. Start a diuretic to reduce proteinuria and control his blood pressure. D. Refer him for a kidney transplant evaluation due to the presence of proteinuria. Answer: B. Add an ACE inhibitor or ARB to help protect his kidneys and reduce proteinuria. Explanation: the presence of an elevated urine albumin to creatinine ratio in this patient with type 2 diabetes suggests early diabetic nephropathy. The most effective intervention to reduce further kidney damage is the initiation of an ACE inhibitor or angiotensin receptor blocker (ARB, which can reduce proteinuria and protect renal function. Increasing the dose of metformin, option A, may be inappropriate given his rising serum creatinine, and while diuretics, option C, can be used for managing fluid retention, they are not the first-line treatment for diabetic nephropathy. Referral for a kidney transplant, option D, is premature and unnecessary at this stage as the patient does not have end-stage renal disease yet. The primary focus should be on controlling the underlying cause, which in this case is diabetic nephropathy. Question 18. A 70-year-old woman with a 15-year history of type 2 diabetes, hypertension, and her previous myocardial infarction presents for her annual checkup. She reports feeling generally well, but her recent lab work shows an HbAC of 7.5%, an elevated serum creatinine of 1.8 mdl, and a urine albumin to creatinine ratio of 300 mdg. She is currently metformin, lisinopril, and a statin. What is the most appropriate next step in her management? Add a sodium glucose cotransporter GLT2 inhibitor to improve both glycemic control and kidney function. B. Increase the dose of her metformin to further control her blood glucose levels. C. Discontinue her statin and switch to a fibrate to better manage her cholesterol. D. Start a high-dose loop diuretic to control her hypertension and edema. Answer A. Add a sodium glucose cotransporter GLT2 inhibitor to improve both glycemic control and kidney function. Explanation. Given the patient's history of type 2 diabetes, myocardial infarction, and now signs of diabetic kidney disease, elevated creatinine, and albuminuria, the best step is to add an GLE2 inhibitor. These medications are proven to not only improve glycemic control but also reduce the progression of diabetic kidney disease and lower the risk of cardiovascular events. Increasing metformin, option B, is unlikely to be effective in improving her kidney function and may be contraindicated at higher doses due to her elevated creatinine. Switching from a statin to a fibrate, option C, is not appropriate as statins have clear benefits for cardiovascular risk management, especially in patients with diabetes. Loop diuretics, option D, may be used for fluid retention but do not address the underlying kidney disease or improve her overall management for diabetic kidney complications. Question 19. A 63-year-old woman with type 2 diabetes presents with complaints of progressive numbness and tingling in her feet, which has worsened over the past several months. She has a 10-year history of diabetes and her HbAC is currently 8.1%. Her blood pressure is well controlled with an ACE inhibitor and she is also on a statin. On examination, she has reduced sensation to light touch and vibration in both feet. What is the most appropriate next step in managing her condition? A. Start gabapentin for neuropathic pain and consider optimizing her blood glucose control. B. Increase the dose of her statin to reduce the risk of cardiovascular events. C. Begin an antidepressant to help manage her neuropathic symptoms. D. Refer her for a vascular surgery evaluation due to the risk of peripheral artery disease. Answer A. Start gabapentin for neuropathic pain and consider optimizing her blood glucose control. Explanation. The patient's symptoms of numbness and tingling in the feet are consistent with diabetic peripheral neuropathy, common complication of long-standing diabetes. The most appropriate next step is to start gabapentin or another medication such as pregabalin to help manage neuropathic pain. Additionally, optimizing blood glucose e.g. through more effective management or medication adjustments is crucial in slowing the progression of neuropathy. Increasing the statin dose, option B, would not directly address her neuropathic symptoms, and antidepressants, option C, are not first-line treatments for diabetic neuropathy. Vascular surgery referral, option D, is unnecessary as there is no indication of peripheral artery disease in this patient at the moment. Question 20. A 48-year-old man with a 6-year history of type 2 diabetes presents for follow-up. He has had suboptimal glycemic control with an HbAC of 8.2% despite being on metformin and glipizide. His blood pressure is 138/88 mmHg and his lipid profile is within normal limits. He is concerned about the long-term risks of poorly controlled diabetes. What would be the addition to his current regimen to improve both his blood glucose control and long-term outcomes? Add a euphoria inhibitor to improve glycemic control with a low risk of hypoglycemia. B. Switch to insulin therapy to achieve better control of his blood glucose levels. C. Add a ion receptor agonist to improve glycemic control, aid in weight loss, and reduce cardiovascular risk. D. Start thiazolidinediene TD to improve insulin sensitivity. Answer. C. Add a ion receptor agonist to improve glycemic control, aid in weight loss, and reduce cardiovascular risk. Explanation. 4. A patient with suboptimal glycemic control despite current therapy, ion receptor agonist is an excellent choice. GLP-1 agonists improve glycemic control, promote weight loss, and have proven cardiovascular benefits in patients with type 2 diabetes. This combination addresses patients' glycemic control while providing additional benefits for weight management and cardiovascular risk. Adding DPP-4 inhibitor, option A, could be a reasonable option but does not offer the same weight loss or cardiovascular benefits as GLP-1 receptor agonist. Switching to insulin, option B, may be necessary in some cases, but it may not be the best first option and may lead to weight gain and hypoglycemia. Thiazolidinedienes, option D, can improve insulin sensitivity but are associated with side effects such as weight gain, fluid retention, making them less suitable for this patient. Question 21. A 50-year-old male patient with type 2 diabetes has a history of obesity, hypertension, and hyperlipidemia. His most recent H-back is 8.5% and his blood pressure is 104/9 mmHg. His lipid profile shows an elevated LDL level of 106 mdl and triglycerides of 250 mgdl. He is currently taking metformin, atorvastatin, lisinopril. He also reports feeling fatigued despite sleeping well and has noticed increasing swelling in his lower extremities. Upon examination, he has a body mass index (BMI) of 32 kilograms and blood pressure of 104/9 mmHg. What is the most appropriate next step in the management of this patient? A. Increase the dose of atorvastatin to target the LDL goal. B. Start sodium glucose cotransporter 2 EDLA 2 inhibitor to improve both glycemic control and cardiovascular outcomes. C. Discontinue lisinopril and initiate calcium channel blocker for blood pressure control. D. Begin loop diuretic to address the lower extremity edema without adjusting any other medications. Answer B. Starter sodium glucose cotransporter 2 IGLT2 inhibitor to improve both glycemic control and cardiovascular outcomes. Explanation: this patient has several risk factors for cardiovascular disease, including obesity, hyperlipidemia, hypertension, and poorly controlled diabetes. In this context, the addition of an SGLT2 inhibitor would be the most appropriate next step. These medications improve glycemic control and provide substantial cardiovascular protection, including a reduction in heart failure risk and diabetic kidney disease. Increasing the dose of atorvastatin, option A, might be beneficial for lipid management, but it does not address the patient's glycemic control or overall cardiovascular risk in the same way a SGLT2 inhibitor would. Discontinuing lisinopril and switching to a calcium channel blocker, option C, would be inappropriate, as ACE inhibitors like lisinopril provide renal protection in diabetes. Starting a loop diuretic, option D, is not ideal, as the patient's edema may be related to other factors, and treating the underlying diabetes and cardiovascular risk should take priority. Question 22. A 45-year-old woman with type 1 diabetes presents for a routine checkup. Her H-back is 7.2% and she reports no major changes in her health. She has been using insulin therapy for over 20 years and is currently on a basal bolus regimen with insulin glargine and insulin aspart. On examination, her weight is stable and her blood pressure is within normal limits. However, her blood glucose log reveals that she often experiences postprandial hypoglycemia, especially after meals with higher carbohydrate content. What is the most appropriate adjustment to her current treatment plan? A. Add a rapid-acting insulin bolus at every meal to better control postprandial glucose levels. B. Switch her insulin regimen to a premixed insulin formulation to reduce complexity. C. Increase her insulin glargine dose to address postprandial hypoglycemia. D. Recommend that she adopt a low-carb diet to better control her blood glucose levels. Answer A. Add a rapid-acting insulin bolus at every meal to better control postprandial glucose levels. Explanation: in patients with type 1 diabetes who experience postprandial hypoglycemia, the most appropriate intervention is to add a rapid-acting insulin bolus, option A, at each meal. This will help better control the spikes in blood glucose that occur after meals, particularly those with higher carbohydrate content. Switching to premixed insulin formulation, option B, is generally not ideal for patients with type 1 diabetes, as it does not provide the flexibility needed for precise control of both basal and prandial insulin. Increasing the insulin glargine dose, option C, would primarily address basal insulin needs and is unlikely to improve postprandial hypoglycemia. A low-carb diet, option D, may help reduce postprandial glucose levels. Should not be the first-line approach without careful monitoring of nutritional intake and insulin adjustments. Question 23. A 62-year-old woman with type 2 diabetes presents for a follow-up visit. Her most recent H-back is 8.4% and she reports feeling increasingly fatigued over the past few months. Her past medical history includes hypertension, hyperlipidemia, and diabetic retinopathy, which was diagnosed 2 years ago. She is currently taking metformin, atorvastatin, and lisinopril. Examination: her blood pressure is 130/85 mmHg and her weight is stable. Urinalysis shows a microalbuminuria of 30 mdg, What is the most appropriate management strategy for her diabetic kidney disease at this time? A. Initiate a sodium glucose cotransporter to SGLT2 inhibitor to slow the progression of diabetic nephropathy. B. Start an angiotensin receptor blocker ARB to further protect her kidneys. C. Increase her statin dosage to further lower her cholesterol and prevent cardiovascular events. D. Refer her to a nephrologist for dialysis evaluation due to the presence of microalbuminuria. Answer A. Initiate a sodium glucose cotransporter to SGLT2 inhibitor to slow the progression of diabetic nephropathy. Explanation: the presence of microalbuminuria, 3-MDG, is an early sign of diabetic nephropathy. The most appropriate next step is to initiate an SGLT2 inhibitor, option A, which has been shown to reduce albuminuria and slow the progression of kidney disease in patients with diabetes, while angiotensin receptor blockers, ARBs option B, are effective in protecting the kidneys in patients with diabetes and proteinuria. SGLT2 inhibitors offer additional renal and cardiovascular benefits. Increasing the statin dose, option C, may be beneficial for cardiovascular risk management but does not address her kidney disease. Referring her for dialysis evaluation, option D, is premature as her kidney function is still relatively preserved. The focus should be on optimizing diabetes and blood pressure management. Question 24. A 58-year-old man with type 2 diabetes presents for an annual checkup. He has been experiencing increased thirst, frequent urination, and weight loss despite having an H-back of 6.9%. His recent lipid profile shows an LDL of 108 mg/dL, a 35 mg/dL, and triglycerides of 250 mg/dL. His blood pressure is 135/85 mmHg, and he is currently taking metformin. On examination, he has an ER of 30 kilograms and his feet show signs of early neuropathy. What is the most appropriate next step in his management? A. Initiate GLP-1 receptor agonist to improve glycemic control and promote weight loss. B. Start an SGLT2 inhibitor to improve glycemic control and address his risk of cardiovascular disease. C. Add second oral hypoglycemic agents such as sulfonylurea to help control his blood glucose. D. Refer him for bariatric surgery to address his obesity and improve diabetes management. Answer B. Start an SGLT2 inhibitor to improve glycemic control and address his risk of cardiovascular disease. Explanation: given the patient's elevated blood glucose levels, poor lipid profile, and risk of cardiovascular disease, initiating an SGLT2 inhibitor, option B, is the most appropriate next step. These medications help improve glycemic control, promote weight loss, and provide cardiovascular protection. Critical for this patient. Starting a GLP-1 receptor agonist, option A, is another potential option as it can also promote weight loss and improve cardiovascular outcomes. GLP-2 inhibitors have shown more robust cardiovascular benefits in patients with type 2 diabetes. Adding a sulfonylurea, option C, may help lower blood glucose but could result in weight gain and hypoglycemia, making it a less favorable choice. Bariatric surgery, option D, is a consideration for patients with severe obesity, but it should not be the first-line intervention for managing diabetes and should be considered only after other treatment options have been exhausted. Question 25. A 70-year-old male patient with type 2 diabetes presents with complaints of increased fatigue, poor wound healing, and frequent infections. His H-back is 8.5% and his blood pressure is 148 mmHg. He is currently taking metformin and a statin. He has a history of diabetic retinopathy and neuropathy, but no known history of nephropathy. His examination reveals deep sensation in his feet and mild swelling in both lower extremities. What is the most important intervention to address his current symptoms and prevent further complications? A. Initiate a GLP-1 receptor agonist to improve his glycemic control and reduce cardiovascular risk. B. Optimize his blood glucose control with adjustments to his current diabetes regimen. C. Refer him to an endocrinologist for insulin therapy to control his blood glucose more effectively. D. Start a high-dose corticosteroid to help improve his wound healing and reduce fatigue. Answer B. Optimize his blood glucose control with adjustments to his current diabetes regimen. Explanation: this patient is experiencing symptoms suggestive of poorly controlled diabetes, including fatigue, poor wound healing, and frequent infections. The most important intervention is to optimize his blood glucose control, option B, through adjustments to his current diabetes regimen. This may include intensifying his current therapy or considering the addition of other medications, such as SGLT2 inhibitors or GLP-1 receptor agonists, to improve his glycemic control. Optimizing blood glucose levels is crucial to prevent further complications like diabetic neuropathy, retinopathy, and poor wound healing. Initiating AION receptor agonist option A could be beneficial in improving glycemic control and providing cardiovascular benefits, but the immediate priority for this patient is addressing his uncontrolled diabetes. Referring to an endocrinologist for insulin therapy option C might be necessary in the future if his blood glucose continues to be poorly controlled, but the first step should be optimizing his current regimen. Starting a high-dose corticosteroid option D would not be appropriate for this patient, as it could exacerbate hypoglycemia and lead to further complications in diabetes management. Question 26. A 75-year-old woman with a long history of type 2 diabetes and hypertension presents with complaints of blurred vision and difficulty seeing at night. She also mentions that her feet feel numb and that she has difficulty walking long distances. Her HbAC is 7.8% and her blood pressure is 135/85 mmHg. On examination, she has diminished sensation in her feet. Endoscopy reveals the presence of microaneurysms and cotton wool spots. What is the most likely cause of her symptoms and what is the recommended management? A. Diabetic retinopathy and neuropathy. Control blood glucose and blood pressure and consider referral to an ophthalmologist. B. Cataracts and diabetic neuropathy. Prescribe corticosteroids and refer to ophthalmology. C. Hypertensive retinopathy and diabetic neuropathy. Optimize antihypertensive therapy and monitor vision. D. Age-related macular degeneration and diabetic neuropathy. Recommend low vision aids and start physical therapy. Answer A. Diabetic retinopathy and neuropathy. Control blood glucose and blood pressure and consider referral to an ophthalmologist. Explanation. The patient's blurred vision and night blindness, along with the findings of microaneurysms and cotton wool spots on fundoscopy, indicate diabetic retinopathy, common complication of poorly controlled diabetes. The numbness and difficulty walking are suggestive of diabetic neuropathy, another complication. The best approach is to optimize blood glucose control and blood pressure management to prevent further progression of both retinopathy and neuropathy. Referral to an ophthalmologist is important for further evaluation and management of the retinopathy. Cataracts option B and age-related macular degeneration option D are potential causes of vision changes in older adults but are not supported by the findings. Fundoscopy, hypertensive retinopathy option C is unlikely given the patient's well-controlled blood pressure. Question 27. A 60-year-old man with type 2 diabetes is evaluated for his annual checkup. His HbAC is 8.1% and he reports experiencing increasing fatigue, polyuria, and thirst. He has a history of diabetic retinopathy, but no history of diabetic nephropathy or cardiovascular disease. He is on metformin and a statin for his cholesterol. On examination, his blood pressure is 138 mmHg and his EMI is 29 kg. His urine analysis shows trace proteinuria. What is the most appropriate next step in his management? A. Increase his metformin dose and add second oral hypoglycemic agent to improve glycemic control. B. Initiate an SGLT2 inhibitor to improve glycemic control and address early signs of diabetic nephropathy. C. Refer him for nephrology evaluation due to the presence of proteinuria. D. Start insulin therapy to more aggressively control his blood glucose levels. Answer B. Initiate an SGLT2 inhibitor to improve glycemic control and address early signs of diabetic nephropathy. Explanation. The presence of trace proteinuria in this patient suggests early signs of diabetic nephropathy. SGLT2 inhibitors have been shown to improve both glycemic control and provide renal protection, making them the most appropriate choice for this patient. Increasing the metformin dose option A might help blood glucose control, but it does not address the proteinuria or provide the renal protection that an SGLT2 inhibitor offers. Referral to a nephrologist option C is premature as the patient does not have significant nephropathy yet, and the addition of an SGLT2 inhibitor is an appropriate first-line intervention. Starting insulin therapy option D would not be necessary at this point as his HbAC is not sufficiently elevated. Warrant insulin initiation. Question 28. A 45-year-old woman with type 2 diabetes presents for follow-up. She has had diabetes for over 10 years and reports that her blood glucose control has been difficult to manage recently. Her HbAC is 9.2% and she reports frequent hypoglycemic episodes. She is currently on metformin, glipizide, and a statin for cholesterol. On examination, she is overweight with a YA of 32 kilograms and her blood pressure is 135/85 mmHg. What is the most appropriate adjustment to her current diabetes regimen? A. Discontinue glipizide and initiate GLP-1 receptor agonist to help with both glycemic control and weight loss. B. Increase the dose of glipizide to achieve better glycemic control. C. Add an insulin regimen to better control her blood glucose levels. D. Switch from metformin to thiazolidinediene to improve insulin sensitivity. Answer: A. Discontinue glipizide and initiate a receptor agonist to help with both glycemic control and weight loss. Explanation: glipizide sulfonylurea can cause hypoglycemia, especially in patients with type 2 diabetes who may have variable insulin sensitivity. Discontinuing glipizide option A and initiating a receptor agonist is the most appropriate adjustment, as these medications help improve glycemic control and promote weight loss without the risk of hypoglycemia. Increasing the dose of glipizide option B would increase the risk of hypoglycemia, which is already a concern for this patient. Adding an insulin regimen option C is premature given that non-insulin therapies could still improve her control. Switching to a thiazolidinediene option D could help with insulin sensitivity but is less effective. The GLP-1 receptor agonists and carries a risk of weight gain which is undesirable in this patient. Question 29. A 50-year-old male patient with type 2 diabetes presents for an annual review. His HbAC is 7.5% and he is concerned about the worsening tingling and numbness in his feet. He reports that the sensation is particularly worse at night. He has been on metformin for years and his blood pressure is well controlled with an ACE inhibitor. Upon examination, he has decreased sensation to monofilament testing in both feet. What is the most appropriate next step in his management? A. Increase the dose of metformin to better control his blood glucose levels. B. Refer him for a thorough evaluation of his diabetic neuropathy and start a pain management regimen. C. Add an SGLT2 inhibitor to improve both glycemic control and renal protection. D. Start a statin to reduce the risk of cardiovascular events. Answer: B. Refer him for a thorough evaluation of his diabetic neuropathy and start a pain management regimen. Explanation: this patient's symptoms of tingling, numbness, and loss of sensation are consistent with diabetic neuropathy, which is a common complication of type 2 diabetes. The next step should be thorough evaluation of his neuropathy, including tests such as nerve conduction studies or other diagnostic workups. Pain management regimen, which may include medications such as pregabalin or gabapentin, can help alleviate his symptoms, while increasing the dose of metformin. Option A could improve blood glucose control. The primary concern here is managing the neuropathy. Adding an SGLT2 inhibitor, option C, could improve glycemic control but would not directly address the patient's neuropathy. Starting statin, option D, is important for cardiovascular risk management but should not be the immediate focus for this patient with neuropathy symptoms. Question 30. A 66-year-old female patient with type 2 diabetes presents for her annual checkup. Her HbAC is 7.0% and her blood pressure is 130 mmHg. She is overweight, BMI of 31 kilograms, and has history of diabetic retinopathy. She is currently on metformin and atorvastatin. During the visit, she reports that her vision has been blurry at times and she is experiencing episodes of dizziness and lightheadedness. What is the most appropriate next step in her management? A. Increase her atorvastatin dosage to reduce her cholesterol further. B. Refer her to an ophthalmologist for comprehensive eye exam to evaluate her retinopathy. C. GLP-1 receptor agonist to improve glycemic control and promote weight loss. D. Add an ACE inhibitor to address her blood pressure and protect her kidneys. Answer: B. Refer her to an ophthalmologist for a comprehensive eye exam to evaluate her retinopathy. Explanation: given the patient's history of diabetic retinopathy and her current symptoms of blurry vision, the most appropriate next step is to refer her to an ophthalmologist for a comprehensive eye exam to assess the progression of her retinopathy and to ensure timely intervention if necessary. Although increasing atorvastatin option might help further reduce her cholesterol, it does not address her immediate concern, Starting, a young receptor agonist, option C, could benefit a glycemic control and weight loss but should not be prioritized over an exam. Adding an ACE inhibitor, option D, might help with blood pressure control and kidney protection, but the priority here is addressing the progression of the retinopathy.